Good afternoon, everybody. Sorry for me being late. Um, when we started PAME in 2012, when you plan a meeting, the first question you're asked is, well, what about the budget? And in order to have a budget, you need to know how many people. And we had no idea if anyone was going to show up. So I guessed 75 and was pretty close. This breakout session is sort of like that, and I'm very happy to see people here. We didn't know how much interest there would be in doing something that wasn't strictly SUDEP. But clearly premature mortality is much, in epilepsy, is much more than SUDEP. So this is our agenda for the afternoon, and we'll go through it. But one of the things I want to stress is that, if at all possible, this shouldn't be a series of didactic presentations. This should be some didactics and then some discussion in the group, because the whole idea is to motivate research and learn from each other. So let's try and do that as much as possible. Why do we have this session? And the answer is that in every series, and I'm not going to show you the whole literature because that's not what we're here for. In every series of mortality, there's the emphasis on deaths related to epilepsy, and here you see SUDEP. That's the box that we normally focus on. What we tend not to focus on are the other causes, pneumonia being the leading one. This is a 40-year study from Finland that will never be replicated. And what you see are other causes of premature mortality. You see suicide. We heard about that this morning. That should be part of PAME. There's the other causes of death, and we don't know what those are. In a paper put together a number of years ago, Elizabeth Donner was the first author. It was a compilation of premature mortality in children with epilepsy. This is all deaths. And although we tend to look at the epilepsy stuff, look at the natural causes. And the natural causes are in the dark bars. So they're larger than the epilepsy causes across this series. And as you see, there's things like underlying neurologic etiology, brain tumor, NMD, neurometabolic disease, other neuropneumonia, suicide, homicide. So it's there, we just haven't paid attention to it in the way that we should have. And in looking at the non-epilepsy causes, you can see metabolic neurodegenerative. So it's something that's always been in front of us that we need to address. Now, I will be the first one to say that we are all looking for cures for epilepsy, for inborn errors of metabolism, for Alzheimer's disease. We're looking for cures. That's what we want. We know that they're not going to be forthcoming in the next 5 years in the way that we want. So what are we going to do before then? Inborn errors of metabolism, neurodegenerative Alzheimer's disease, major issues. They're the big tickets, but underlying it is the issue of the associated seizures and the potential role of causing premature mortality. And that's what got us here. I want to thank our speakers. Oh, and this is from Warren Davinsky in his classification of epilepsy-related deaths, and you see metabolic neurodegenerative at the bottom. So it's part of our thinking. Now, with that, I want to thank our speakers. Charity and Stephen Adams have come a long way to tell an important story, and this is why we're here. That's why we're here. My colleagues from Boston, Phil Pearl and Dr. Latzer, are going to cover the inborn errors of metabolism something that we have not included here previously. And Dr. Zawar from UVA will talk about the emerging field of seizures related to the dementias and potential role in premature mortality. So this is a first of its kind, pretty exciting, and thank you all for participating. So with that, Charity.
Thank you. It's an honor to be asked to sit amongst these beautifully altruistic people that have devoted their lives to helping others. But it's peculiar. This is only the second time I've met Dr. Pearl. Our first was 3 months before the event that forever changed my family. Yet during that meeting, I never imagined it was me Dr. Pearl would be saving. So thank you. I'm getting ahead of myself. Let me introduce my gorgeous party of 3. Stephen, my Australian husband, and our beloved son, Mr. Bond Walter Toohey. We've lived in Dubai for over 20 years, and as devout expats, we're at our happiest when boarding an airplane. Mr. Bond was an easygoing baby, happily engaging in the world around him. But developmental delays were evident, and by age 2, our excuses had worn thin. A well-intentioned doctor diagnosed him with high-functioning autism, or PDD-NOS. It was the first acronym to define our lives. We were unconvinced, so we just stayed focused on elevating Bond beyond his limitations, and through intensive therapies, he made substantial progress. But we still struggled with a severe language delay. And although we had sought advice from doctors across the globe, it was a visiting pediatric neurologist in Dubai who took one look at Bond and immediately suspected an inborn error of metabolism and expressed frustration for the lazy autism diagnosis, something I would hear many times after that. So a simple urine test gave weight to his inclinations, and DNA sequencing confirmed them. I'll try my best, Dr. Pearl. Succinic semialdehyde dehydrogenase deficiency. I think I botched it. Let's just go with our second acronym, SSADHD. We were now part of an ultra-rare disease family whose global numbers only total 350. Bond presented with several symptoms like expressive language and intellectual delays, but there was one glaring box we did not tick: epilepsy. This was true until the discombobulating hormones of puberty decided otherwise. It was an early morning in a very quiet corner of Thailand. Stephen shook me awake. Bond was frozen by a tonic seizure. When a second, this time tonic-clonic, arrived a month later, we placed all our hopes in medicine. Sadly, the first only managed to turn him into the Incredible Hulk. While others gave us back our darling boy, none were able to control the seizures. An embraced watch provided the independence teenage Bond craved, but as his epilepsy refused to be tamed, we knew it was time to visit the rock star of our SSADHD world, Dr. Pearl. It fits, I think. Dr. Pearl quickly won us over. For Bond, it was his refuting my objections, noting a beer with Daddy on his 18th birthday would be okay. So my boys high-fived. For us parents, simply being guided by the foremost authority on our rare disease was enough. Mr. Bond also became their first participant in the groundbreaking natural history study for SSADHD. For his copious contributions of data and, I'm assuming, entertainment, Bond was bestowed the title Trailblazer, which I adore. In amongst those conversations of beer, pharmaceuticals, and studies, Dr. Pearl gently mentioned sudden, unexpected death and epilepsy, although rare, was more common with our disease. He's spoken away as to not cause alarm, so I filed that information away until 3 months later, at the start of school holidays, I went to go wake my sleepy boy for his morning meds. And as emergency swirled around me, Dr. Pearl's words kept panic at bay, affording me clarity to ruminate on Bond's final sentiments when kissing goodnight. This always gets me because I can hear him. Love oo gaggy, love oo mummy. Always gaggy first. I accept my third wheel position in their best mates. But even after 5 years, I grappled daily with this petulant brain, surmising ways I could have saved our Bondi. But with a deep breath and a bit of self-praise for still being a good mummy, Dr. Pearl's words continue to provide solace, reaffirming there was nothing I could have done to prevent SUDEP, that final acronym, from defining our lives. And because of resolute doctors, teachers, therapists, and loved ones, Bond had become a confident, happy teenager, living in partnership with an ultra-rare disease. Now, it's Stephen and I who are learning to live in a partnership with grief. And if you'll allow me a final moment of mummy indulgency, I would love to share a memory that perfectly captures Bond's life. We were one of the first families living in a new community, and for Bond, this meant Goonies-type adventures, exploring the desolate streets and winding footpaths. I, maybe not Daddy, but I was comfortable with his two-wheeled explorations if he stopped every few laps to check in. Bond's cheeky interpretation, whizzing past the garden gate, yelling, "Hi, Mummy!" It was an exceptionally beautiful day where that sky just felt infinitely blue. I walked outside and caught a glimpse of Mr. Bond standing on his bike pedals, eyes closed, gazing, basking in the warm sun. His broad, contented smile had said it all. He had found freedom. Mesmerized, I watched as he pedaled into his next lap before realizing that boy was cycling with his eyes closed. It was a moment of revelry for me, just a moment. But for our Bond, this is how he lived every day of his short life. Deeply present, guided by an internal compass of pure happiness. Thank you.
I'm always glad when I don't have to follow the parent. And Dr. Pearl is not a rock star. He's sort of a classical music jazz star, just to be specific. I gotta say that the wisdom. I mean, what I heard and what my colleagues need to hear is the power of saying the word SUDEP before it happens. And a huge issue now. And the second is the immediate reassurance of lack of guilt. Because for those of you that heard our long-term grief study, what folks who were bereaved said was, number one, hearing that SUDEP was the cause was something they really wanted, was important to them. However, one of the consequences was it led to guilt. And that's something that's completely preventable. So thank you. Dr. Zawar, you're up next. Would you like to be up next? Oh, sorry. I was looking. Oh, I thought about maybe doing the inborn first, but I think you're fine.
Yeah.
So Ifra was so kind when we asked her to participate today, and she said, "How long would you like me to talk? This is what I do," and she's really emerged as I think one of the really major people in the field of Alzheimer's disease and epilepsy. So thank you.
Good afternoon, everyone. I really wasn't hoping to follow that. After this, you can probably see still my eyes watery, but I think I can give it a go. So the title of my talk is Epilepsy and Neurodegeneration and Mortality, an Intricate Triad. I have no disclosures relevant to this talk. The objectives of today's talk are to examine the relationship between seizure control and its impact on cognition, mortality, and function in persons with dementia. Next, we'll explore the postmortem neuropathological markers associated with degree of seizure control in individuals with dementia. And finally, we will highlight some of the risk factors linked to the development of epilepsy in persons with dementia. So why are we talking about this mortality related to epilepsy in older adults and persons with dementia? So epilepsy incidence actually has a bimodal distribution that we can see over here, which actually is highest in older adults. Today, we live in a rapidly aging society. As life expectancy is increasing, it is becoming an increasingly important problem. As people are living longer, they're more likely to develop epilepsy. This becomes an even bigger problem in persons with dementia. There's a high incidence of comorbid epilepsy in dementia. Persons with dementia have a 6 to 10-fold higher relative risk of developing epilepsy than the general population. Up to 64% of persons with dementia may develop comorbid epilepsy. So knowing the close association between epilepsy and dementia, the first thing that I wanted to investigate was the association between seizure control and its impact on cognition. So the first part of my talk is based on 39 Alzheimer's disease centers across United States that have been recruiting participants for more than 20 years now. They recruit participants with dementia, mild cognitive impairment, and cognitively healthy adults. And then follow them over time. So I identified around 34,000 participants who had either normal cognition or mild cognitive impairment. I subcategorized those participants into those who had, by their seizure status, into those who had recurrent seizures or who had active ongoing seizures in the past 12 months and were requiring active anti-seizure medications. The next group was remote seizures, those patients who had a prior history of seizures but were not having any active seizures and were not requiring any anti-seizure medications. And lastly, no seizure group that served as controls. I wanted to look at the impact of the varying degree of seizure control on cognition and how these patients with normal cognition of mild cognitive impairment did over time longitudinally, and how many of these patients developed cognitive decline and develop dementia. So the first thing we looked at was the impact of active seizures in cognitively normal adults. We can see in this Kaplan-Meier curve that over 12 to 16 years, the red line represents those with recurrent seizures, the yellow line is remote seizures, and the blue line is controls. We can see the probability of intact cognition was significantly lower among those with recurrent seizures compared to the other groups, which meant they were significantly more likely to develop cognitive decline compared to controls in those who had remote seizures. Because age, education, race, sex, high blood pressure, and diabetes can also influence cognition, we adjusted our model for these factors. And even after adjustment, we found that active or recurrent seizures had a 2.13 times higher risk of earlier cognitive decline to dementia among those who had normal cognition compared to controls or remote seizure participants. Because epilepsy in older adults, or new onset epilepsy in older adults, is very, very common, epilepsy incidence being the highest in older adults, we wanted to look at this entity separately. So we also looked at those participants who didn't have seizures at the time of enrollment, but developed new onset seizures during the follow-up, and wanted to look at that impact on cognition. We found an even more profound degree of cognitive decline among participants who developed new onset seizures in older age. And they were 3.15 times, or 3 times more likely to develop earlier cognitive decline compared to remote seizure participants or controls. And after somebody with normal cognition developed new onset active seizures in older age, the median time to develop dementia was 0.5 years, which meant 6 months after they developed new onset seizures, on average, they would develop dementia. Then we looked at the impact of active or recurrent seizures in mild cognitive impairment. Similarly, we found earlier cognitive decline among active or recurrent seizure groups. But the most significant finding were, again, in new onset active seizures in mild cognitive impairment participants. We found that they were 2.7 times more likely to develop earlier cognitive decline, again, around 3 times higher risk of dementia. And after someone with a mild cognitive impairment developed new onset seizures, the median time to cognitive decline was 0 years, which meant around the time somebody with mild cognitive impairment will report new onset seizures is around the time when they also develop dementia. So we concluded that people with active or recurrent seizures compared to remote seizures had an earlier cognitive decline in both cognitively normal and mild cognitive impairment. New onset seizures in older adults carry a significantly high risk of cognitive decline in both groups, and there's a need for early identification and aggressive management of seizures in cognitively normal and mild cognitive impairment. With that, I'll move to the second part of my talk, which is focused on mortality. So first, identified by G. Mackenzie Bacon and his contemporaries in the 1800s, the concept of premature mortality in persons with epilepsy has since garnered significant attention. SUDEP was formally recognized as a distinct entity in the 1970s, and now we know that all-cause mortality, whether it is related to sudden unexpected death in epilepsy or unrelated to sudden unexpected death in epilepsy, all-cause mortality in epilepsy is 2 to 3 times higher than the general population. And this can be attributed to a multitude of factors, like I said, to epilepsy itself, to sudden unexpected death in epilepsy, and multiple other factors, including external factors. With that, I would move to the specific topic at hand, the association of seizure control and mortality in persons with dementia. So we identified 27,000 plus participants who had mild cognitive impairment or dementia. We subcategorized them again into those with recurrent seizures, remote seizures, or no seizure controls, and then we looked at their mortality outcomes. So the first thing we looked at was the mortality rate. The mortality rate for the entire cohort was 100 per 1,000, but it was significantly higher for those with recurrent seizures at 169 per 1,000, compared to remote seizure participants whose mortality rate was 102 per 1,000 and controls whose mortality rate was 99.3 per 1,000. Similarly, when we looked at the proportion of deceased participant at the most recent follow-up, among recurrent seizure participants, 45% of them had deceased at the most recent follow-up, compared to 31% in remote seizure group and 34% in controls. Then we looked at the average age of death, which was significantly younger among recurrent seizure participants at 73 years, compared to remote seizure participants at 76 years, and controls who had average age of death of 80. So recurrent seizure participants were dying 7 years earlier on average, compared to controls. This is a Kaplan-Meier curve, again showing that the survival probabilities are significantly lower among recurrent seizure participants compared to remote seizure participants and controls. But we also know that there are so many other factors that can contribute to mortality in persons with dementia. So we controlled our model or adjusted our model for age, sex, race, ethnicity, education, high blood pressure, diabetes, high cholesterol, dementia severity, stroke, brain injury, Parkinson's disease, alcohol abuse, depression, and genetic mutation. Pretty much anything that we could identify that has in the literature been associated with high mortality. And we found that even after adjusting for those, recurrent seizure had a significantly high risk of earlier death. They were associated with 1.79, around 2 times higher risk of earlier or premature mortality compared to controls. On average, the median time to death from enrollment for recurrent seizure participants was around 2 years, and it was 4 to 5 years for the other groups. So we concluded that active or recurrent seizures are not only associated with higher mortality rates, but also with premature or earlier deaths in persons with dementia, which can be secondary to multitude of reasons. So the mechanisms by which recurrent seizures may contribute to mortality in dementia, one of them is status epilepticus. We do know that status epilepticus has a significantly higher mortality in older adults compared to younger adults. Sudden unexpected death in epilepsy, as many of us know, is far more common in those with recurrent seizures than those patients who don't have uncontrolled seizures. But then there are external causes, such as falls, burns, accidents, drowning, which are more common in patients with ongoing seizures. Suicide rates in older adults with uncontrolled seizures are significantly higher compared to younger adults with uncontrolled seizures. Comorbidities, very distinct to this patient population, right? In addition to the comorbidities of dementia and epilepsy, they often also have other things like history of trauma, stroke, high blood pressure, cholesterol, diabetes. Many of them may even have brain tumors, and all of these can together contribute to mortality. Medications. Many of the younger adults with epilepsy typically just take epilepsy medications, but older adults, especially who also have dementia, are going to be on multiple medications. Medications can lead to drug-to-drug interaction. They can have more side effects in older adults and persons with dementia, thereby increasing the risk. And there are studies that have shown that anti-seizure medication, especially older generation anti-seizure medication in dementia, are independently associated with mortality. And then seizure-related frailty is another risk. Seizures can also lead to fatal injuries to head, trunk, and limb. They can lead to systemic complications to kidneys, heart, metabolic acidosis. They can cause overheating, heart rhythm disorders, heart dysfunction, lactic acid buildup in blood. These are just some of the mechanisms by which seizures may contribute to mortality in persons with dementia. In the interest of time, I'm not going to go into further detail on this, but recently we published this review article in Epilepsia Open detailing a wide range of causes why older adults with epilepsy and persons with dementia may experience premature mortality. The next part of my talk is focused on seizure control and mood and functional outcome in persons with dementia. So we looked at mood and found that depression was far worse in those with recurrent seizures compared to controls. In terms of functional status, we looked at physical dependence, residency in nursing home, and day-to-day function. While we didn't find any difference in nursing home residents, recurrent seizure participants were more likely to have physical dependence compared to remote seizure participants and controls, and they were much more likely to have worse day-to-day function, which include ability to pay bills, do taxes, shop, play a game, use stove, prepare a meal, keep track of current events, pay attention, remember appointments, and travel, such as drive or use public transport. So now, hopefully, I've convinced you, ongoing or recurrent seizures are associated with worse cognitive outcomes, worse function, worse mood, higher premature mortality, So what are the underlying bases for all of these worse outcomes in persons with dementia? What could possibly be going on in the brain to contribute to worse outcomes in every possible way? To understand that a little bit, we wanted to look at the postmortem neuropathology of persons with dementia. We identified over 10,000 persons with dementia who had deceased. More than 6,000 of those had undergone autopsy. Again, we subcategorized them into recurrent or active seizure participants, remote seizure participants, and no seizure controls. Before I discuss the neuropathology findings of these participants, I want to talk a little bit about the ATN classification of Alzheimer's disease, something you typically don't hear at an epilepsy conference. So Alzheimer's disease is characterized now by ATN. The A stands for amyloid or amyloid plaques or amyloid pathology. The T stands for tau pathology. Tau protein is normally found in the brain, but it can undergo phosphorylation and aggregation and form tau neurofibrillary tangles. And then N stands for neurodegeneration. So in the most simplest way, an Alzheimer's disease brain is characterized by amyloid plaques, tau neurofibrillary tangles, and neurodegeneration. If there is evidence of all A, T, and N pathology that is consistent with Alzheimer's disease, if all three are absent, we consider them normal AD biomarkers. With that in mind, the first thing we looked at was Braak stage, which is a way to stage tau or neurofibrillary tangles in the brain. Stage 0 typically means there is no tau pathology in the brain. There are no neurofibrillary tangles. Stage 1 and 2, as you can see in the first picture, the blue area represents transentorhinal or mesial temporal regions, so very restrictive involvement of the brain with neurofibrillary tangles or tau. In stage 3 and 4, it has a little bit more widespread involvement. We can look at the blue and green areas. And in the last picture, you can see in stage 5 and 6 of Braak, the tau pathology or neurofibrillary tangles will have very extensive involvement, pretty much involving the entire brain. So in summary, higher Braak stage means worse tau pathology and more neurofibrillary tangles and more severe Alzheimer's disease pathology. When we compared these pathologies among active or recurrent seizure participants compared to remote seizure participants and controls, we found significantly higher Braak stages, which means a lot more tau pathology and a lot more widespread neurofibrillary tangles among active seizure participants compared to other two groups. Similarly, seeded score of neurotic plaque density was used to quantify amyloid plaques. As we can see over here, C0, the first picture, shows absence of amyloid plaques. C1 means they have some plaques, C2 means they have moderate plaques, and C3 means they have frequent amyloid plaques in the brain. Comparing active seizure participants to other two groups, we found significantly higher amyloid pathology, much more frequent amyloid plaques in the brain of those with active seizure participants compared to remote seizure participants or controls. So again, higher stages of amyloid pathology, more severe amyloid pathology. Cerebral atrophy or brain shrinkage was used as a measure of neurodegeneration, subcategorized into none, mild, moderate, and severe. And we found, again, active seizure participants had significantly more brain shrinkage compared to other groups. Hippocampal atrophy or shrinkage of the hippocampus was another measure of neurodegeneration, again subcategorized into none, mild, moderate, severe. We found, again, much more severe hippocampal shrinkage among active seizure participants compared to other participants. And in terms of brainstem neurodegeneration, this second picture over here shows locus coeruleus, which is a region of the brainstem which can sometimes have reduced hypopigmentation or reduced pigmentation. Often locus coeruleus hypopigmentation is associated with more severe seizures and higher risk of sudden unexpected death in epilepsy. So again, locus coeruleus hypopigmentation was subcategorized into none, mild, moderate, and severe, and we found much more severe locus coeruleus hypopigmentation among active or recurrent seizure participants compared to other groups. We found in terms of frontotemporal lobar degeneration, which is a type of dementia, we found it was a lot less common in active seizure participants compared to remote and no seizure participants. We found no differences in Lewy body pathology and vascular pathology, which are, again, two of the other common types of dementias. So these findings suggest that ongoing seizures may contribute to more advanced stages of Alzheimer's disease and more advanced ATN pathology in terms of both higher amyloid, tau, and neurodegeneration burden, and can perhaps explain why these patients have worse cognition, function, and earlier mortality, and therefore highlighting the need to treat seizures more aggressively in this patient population. So then it's easy, let's just treat the seizures in persons with dementia, right? But not that easy. Seizures are subtle and under-recognized in the context of dementia. Seizures in dementia are focal with retained awareness without any motor signs, making it difficult to diagnose without an EEG. Often, mild confusion related to seizures may be confused with the manifestation of dementia itself. Diagnosis, there are several studies have shown, may be delayed for more than 10 years. Seizures in dementia are therefore significantly underestimated. So in the last part of my talk, we understand when we treat seizures in dementia, they typically respond well, but identification of seizures is the bigger problem. So perhaps if we can select dementia patient population who's at high risk for seizures, perhaps based on clinical, genetic, and neuroimaging biomarkers and risk factors, we can maybe then screen them with an EEG for early identification of seizures. So as a first step, we looked at clinical and genetic risk factors of epilepsy or seizures in dementia. We found that the presence of ApoE4 allele is a genetic risk factor for epilepsy in dementia. Some of you may know that ApoE4 allele is a risk factor for Alzheimer's disease dementia in general, but even within dementias, it is a risk factor for epilepsy or seizures in dementia. In terms of clinical risk factors, we found that the presence of Parkinson's disease, increasing severity of dementia, a history of stroke or transient ischemic attack, age of onset of dementia before 60, and Alzheimer's disease as the subtype of dementia were the clinical risk factors associated with epilepsy in dementia. So the take-home point, and now we're also looking at some of the neuroimaging biomarkers of epilepsy in dementia. So the take-home points are there's a high incidence of comorbid epilepsy in dementia. Poor seizure control in dementia is associated with worse cognitive, clinical mortality, and functional outcomes. Treatment of seizures may potentially slow the progression of cognitive decline and potentially improve other outcomes. But seizures are under-recognized in the context of dementia. So maybe we can use clinical and genetic risk factors and perhaps neuroimaging biomarkers to identify high-risk persons with dementia who may be considered for an EEG to identify and treat seizures early on. So far, the clinical risk factors that we have identified for seizures in persons with dementia include Alzheimer's disease subtype of dementia, onset of dementia before 60, increasing severity of dementia, a stroke or transient ischemic attack, and Parkinson's disease. Genetic risk factor for epilepsy or seizures in persons with dementia include ApoE4 allele. And these are my sources of funding. And many people to acknowledge: family, mentors, more mentors, more mentors, collaborators, research assistants. So, and then I put all of their names on this painting that I made, which I made it black and white, and then I put their names on it. Thank you for your attention.
I think we've just been treated to the state of the art in Alzheimer's, epilepsy, and mortality. Perhaps we could have a next set of talks and then have questions at the end. Is that okay, Yufra?
Yeah.
You just sit wherever you're most comfortable. That's what I do. Now my pleasure to introduce Dr. Philip Pearl, Professor of Neurology at the Harvard Medical School, Boston Children's Hospital, holder of the William G. Lennox Chair. Phil.
Thank you. First of all, Dr. Zawar, that your talk really hits home as well. I mean, with the aging of the population, when the medical students come to me looking for a career in neurology, I don't steer them away from adult neurology because of the prevalence of dementia, including Alzheimer's in my 92-year-old mother. So thank you for that. I don't get to hear about it often enough. That was wonderful. To Jeff Buckholter, thank you for organizing this session, bringing inborn errors of metabolism to PAME. It also enabled us to bring this wonderful family, Charity Adams, Steve Toohey. Charity, your comments were just, I hope this was recorded. Frankly, your words are poetic. I mean, it was listening to poetry. I mean, incredible speaking. And we are convinced in our field that although you are members of an elite group to which no one would want membership, having a child with a genetic metabolic disease, we are convinced that studying that group is going to just unravel the mysteries behind epilepsy, SUDEP, intellectual deficiency, and we are studying the disease that your son had intensely. And my colleague, Dr. Itai Tokatli-Latzer, who is on the faculty of Tel Aviv Medical University and who is working with us in Boston in the metabolic epilepsies, is going to do this with me. So this is going to be a tag team. And our presentation is on SUDEP and mortality because, as Jeff said, it's not all SUDEP, especially in this category. And even though inherited metabolic disorders are rare, in our lives, it's common because we see them all the time. That's what we do. Now, I'm afraid this is too basic, but we were kind of told to define things. So what do we mean by inherited metabolic epilepsy? You know, is a disease that's inherited, although it can be de novo. It may not come from any known family history, but the point is we're talking about metabolism. So we're talking about inborn errors of metabolism, and our metabolism, of course, is, sort of, when I'm talking to a child, breakfast, lunch, and dinner, right? Carbohydrates, fats, proteins. So disorders of the metabolic pathways. And then we're talking about disorders. But overall, inborn errors of metabolism are associated with a huge increase in mortality, 21 times. I mean, there's too much data on the slide, but if you break down the metabolic disorders that are broken down on the slide, we talk about epilepsy having a 2 to 3 times increased mortality. In these disorders, it's a 21 plus increase in mortality. And the most common reasons are not actually neurologic in this patient population, broadly speaking. Respiratory, lung problems, digestive, GI, liver problems, infectious diseases. These are the most common causes of mortality in this population. Now, our focus, of course, is on the inherited metabolic epilepsies. So what we mean by that are inherited disorder, inborn errors of metabolism, or inherited metabolic disorders is the current parlance, in which seizures are a prominent part of the presentation or just a prominent part of the phenotype. And this comes from an article that Itai and I wrote for Ninad Blau's series called the Footprints of Metabolic Diseases, and we were asked to do the footprint of inherited metabolic epilepsies. Other people would do it on liver or, kidney or cardiac. And of the about 1,500 known inherited metabolic disorders, about 250 of them qualify as inherited metabolic epilepsy. So there are a lot of these conditions, and SSADHD is one of them. It's so fascinating because it gets into GABA aminobutyric acid, the major inhibitory neurotransmitter of the brain, because, the holy grail for us in epilepsy is the excitatory to inhibitory ratio of the brain. Too much excitation, too little inhibition, you get seizures, with glutamate being the major excitatory neurotransmitter of the brain, just like glycine is for the brainstem and spinal cord, and GABA being the major inhibitory neurotransmitter of the brain. So we're going to get into that disease in very detail because of that IE ratio or EI ratio, excitation to inhibition. But then the question is, what causes seizures in these disorders? Well, here are a couple bullet points. One is one may be deficient or accumulate some compound that's necessary, like ammonia. I mean, if you can clean the kitchen floor with it, ammonia's got to be pretty toxic, right? So you don't want your ammonia to build up, but that's exactly what happens in the urea cycle disorder. So that's an example of a small molecule disorder. Or you can have a large molecule compound that accumulates, causing like the lysosomal enzyme storage disorders or the peroxisomal disorders with the very long chain fatty acids, or the congenital disorders of glycosylation where we form these glycoproteins by putting glycosylated molecules onto proteins. We make glycoproteins, which are important for all kinds of functions in the endoplasmic reticulum, the Golgi body anchoring. So that's what we mean by the large molecule disorders. Or you can have a defect in cellular energy. Like the main metabolic fuel to the brain, of course, is glucose. We use the ketogenic diet to get around glucose. But if you have glucose transporter deficiency, you can't transport glucose into your brain and through your blood-brain barrier, or a mitochondrial disease because you need the mitochondrial respiratory chain to form ATP, the energy compound. So another reason why you might have seizures in these disorders, or the most interesting really in a way, are those where you have a deficiency of a vitamin, like vitamin B6, pyridoxine, which is a cofactor to produce GABA, as well as 150 other reactions in the brain. And so there are vitamin dependency states. Now, vitamin deficiency state is where you have a lousy diet, so you're deficient in your vitamin and you need to replete it and maintain it. But a vitamin dependency state is where you have an inherited disorder involving the vitamin, and even a physiologic dose, not a pharmacologic dose, should be beneficial. But these vitamin dependency states are fascinating inherited metabolic epilepsies. And then there's neurotransmission. Now we get to SSADHD, where neurotransmission is where one neuron has to talk to another, or the glia has to talk to the neuron, and we do it through the neurotransmitters, GABA being the major inhibitory one. So this slide looks too complicated to me to explain, but it comes from Dr. Sauterbrey's textbook, which is an authoritative textbook on inherited metabolic disorders, and talks about these different categories of small molecules accumulating or being deficient, or large molecule problems or energy problems that can all cause epilepsy. What about SUDEP? Well, this whole meeting is about SUDEP, and of course, SUDEP involves a combination of factors. We don't completely understand it: respiratory, cardiovascular, autonomic. One of the common, ways of thinking about SUDEP is that there's a patient basically has a massive seizure from which the patient cannot be resuscitated. That's my view of SUDEP. My sort of layman's, the way I explain to a family is patient, massive seizure can't be resuscitated. There's this theory that adenosine is involved, and there's hypoxemia, and the heart slows down, and the heart stops, get cardiac arrest, and it's the terminal sequence of events. Of course, seizures can induce cardiac arrhythmias, and serotonin's been discussed as well. Now we're going to get into these genetic metabolic epilepsies. So these are genetically based disorders. Now, everyone here already knows there are a bunch of genes with a really high risk of SUDEP, just like our metabolic disorders. Most of them are the channelopathies: sodium channel 1A, 2A, 5A, 8A, potassium channels, even DEPDEC5, which is not a channelopathy. But these, when we have I think the difference, like you said, Charity, with the families with these conditions is they've all heard about it because it's part of dealing with these disorders. Now, of course, in anybody with epilepsy, there are established risk factors for SUDEP, and these are the families that we have to talk to SUDEP about, no matter how benign the underlying cause is. So it may not have anything to do with a metabolic disorder, but if there's a lot of generalized tonic-clonic seizures, nocturnal seizures, person living alone, problem with sticking to the anti-seizure medications or not optimizing the anti-seizure medications or just not being seizure-free, these are all high risk factors for SUDEP. But the interaction between SUDEP and the inherited metabolic disorders is a further complicating thing, because many of these disorders are characterized by drug-resistant and progressive epilepsy. We're going to hear from Itai in a moment about our studies in epilepsy in SSADH deficiency, and this is what we're seeing. And also there are other things involved, like these disorders have other comorbidities, right? Intellectual disability, structural brain abnormalities, and many of them with abnormal MRIs and other neurological abnormalities, including movement disorders that are, subcortical, say extrapyramidal or basal ganglia. Psychiatric comorbidities, which we heard about this morning as well, with the depression and suicide. And sometimes they're more vulnerable to infectious diseases, cardiac involvement, and other problems: ketoacidosis, lactic acidosis, and cerebral edema and herniation. Of course, inherited metabolic disorders are associated with sudden infant death, right? like the fatty acid oxidation disorders, urea cycle, and the organic acidureas, all high incidence of sudden infant death. And a lot of these can present in the neonatal period. Some of them are detectable in newborn screening. That's kind of another discussion. So we have 3 quick examples. One example per slide, then we're going to get into Itai's presentation. So one example would be inherited metabolic disorders with heart problem. That makes sense, right? Underlying cardiomyopathy is going to be a high risk of SUDEP. A lot of these are linked to glucose or sugar transport disorders. GLUT3 is mentioned there. There are other glucose transporters than one. Pentose phosphate, which is carbohydrate metabolism, glycogen metabolism, the disorders of glycosylation. Then there's mito. Now, so here, this comes from a study where they showed that about 15% of patients with underlying mitochondrial disease had premature mortality. So a high risk of early mortality. And in these patients, the duration of the illness was only about 4.5 years, age of death, about 6 years, plus or minus 3 years. Most common causes of death in these patients, sepsis, pneumonia, coagulopathy, and sudden unexpected death. Seizures often a part of it. And early death in these patients tends to be associated with lesions we're used to seeing in mitochondrial disorders like Leigh syndrome, problems in the thalamus, things like that. Here's an EEG, just because a lot of us are EEGers, and you'll see down on the bottom in that right occipital channel marked P402, and then there's a P802, those rhythmic high amplitude delta waves with superimposed spikes or polyspikes, and we see that and we think right away Polgopathy. Although we just had a case of complex 2 deficiency, succinate dehydrogenase deficiency, not succinic semialdehyde, who also had RADS. So anyway, but RADS is an EEG feature. And the third example I'm going to give, classic maple syrup urine disease. A neonate comes in with lethargy, poor feeding, emesis, seizures, alternating hypertonicity and flaccidity, and untreated they get massive cerebral edema. What do I want to say about this? I want to show the EEG. You see those little teeth of the comb over C4 over the right central area. Those are the comb-like waves in maple syrup urine disease, but also seen in propionic acidemia. And then finally, we're going to come to the disease that you heard about from the mom, from Charity. And here's where I'm going to hand over to Itai, who's going to talk about our studies in SSADH deficiency and especially mortality. Itai.
Hi, thanks. So for the last few years, I've been privileged to join the SSADHD community and Dr. Pearl in the natural history study of this fascinating disorder. And Charity, I'd also like to say, I mean, your words really, really affected me. It was so powerful. Thank you for being here today. So I'll tell you a bit about SSADHD and why it's so interesting with respect to epilepsy and to SUDEP. So in this condition, briefly describing the pathophysiology, when you don't have the enzyme SSADH, succinic semialdehyde dehydrogenase, what happens is you have an abundance of GABA, the brain's main inhibitory neurotransmitter. So you would think if someone has a lot of inhibition, basically these people should theoretically sleep all day long, right? Because they have an excess of GABA. But not only do they not sleep all day long, somehow the brain compensates for it, and the imbalance that's formed between excitation and inhibition leads to neurodevelopmental problems, one of which is seizures, which is paradoxical. Again, you would think someone with a lot of inhibition would not have seizures, right? We treat seizures with medications that want the GABA to increase. So how do these people have seizures? We think it's the reason is because of the imbalance between the GABA and the glutamate, the excitation and inhibition. And what you see here in this figure is a synapse, right? 2 neurons that have some kind of connection, and there's an excess of GABA affecting the GABA receptors on the postsynaptic neuron, the one you see below. And what happens that when the GABA receptors continuously are exposed to an excess amount of GABA, eventually they are downregulated, and as these patients grow older, eventually the effect of GABA decreases. So there is some kind of compensation that happens in their brains. Epilepsy in SSADHD, as I said, is frequent. It occurs in about 50% of individuals with this condition, but interestingly, it happens only in later ages, as you said, Charity. And you mentioned that it's part of, being an adolescent and the hormones. It could be a part of it, the hormones. Again, but what we found in our natural history study is that, I'll show you these figures, with age, GABA decreases, GHB, which is another GABA-related metabolite, decreases, and there is overall loss of this inhibitory effect, which causes seizures to evolve, according to our predictive models, around the age of 9 years. So after the age of 9 years, they are prone to having seizures. The SUDEP occurrence rate in SSADHD is extremely high in adults. In our natural history study, including 65 individuals, 33 are adults. Adults are considered above 18 years. 4 have experienced SUDEP. So extremely high, it's considered an extremely high occurrence rate. Why do we think that individuals with SSADHD are more prone to SUDEP? Firstly, because they have an increased occurrence rate of seizures, as Dr. Pearl mentioned. When you have more seizures and more generalized seizures, you're more likely to have SUDEP. And that's maybe the main issue. There could be other explanations for their increased rate of SUDEP, one of which is, SSADHD, as I showed you in this figure. Eventually, the enzyme is located in the mitochondria, and when you don't have the enzyme SSADH, you have less of succinate, a metabolite that links to the tricarboxylic acid cycle. I'm bringing the doctors and researchers here back to second year of medical school, and the tricarboxylic acid cycle, produces energy in addition to other elements that produce energy in the mitochondria. When you have less energy, it affects the balance of adenosine. We know adenosine is linked to SUDEP. There might be a link there. These things have not been studied. And another thing that could explain it is the fact that GABA is a neurotransmitter, and it also affects the populations of other neurotransmitters, one of which is serotonin. And we know that, negatively affecting the serotonin mechanism of the autoresuscitation after seizures could maybe explain the increased risk of SUDEP in this population. There are a lot more things that we need to study linking with respect to SSADH and epilepsy and SUDEP, and we've now gotten a renewal on our natural history study for another 5 years, and we hope to accomplish that. Dr. Pearl, I'll bring the ball back to you. And
Okay. So just to wrap up, I just had to wrap up with this, a reference to great literature. We heard some great poetry. Because when it comes to inborn errors of metabolism, the most eloquent author is no less than Pearl Buck, Nobel and Pulitzer Prize winner in literature, who was in China with her daughter, who was a beautiful child but never developed, very much like Bond, didn't develop intellectually. And they tried a bunch of herbs and stuff like witchcraft and stuff like that. And finally, she was forced to come back to the United States because of this terrible developmental disorder in her daughter. And it turns out, as far as I'm aware, Pearl Buck never learned the diagnosis of her daughter, which ultimately was phenylketonuria, PKU, the first metabolic disease on newborn screening, which came out in the 1950s. But she wrote this book. Everyone knows her for the book, The Round Earth, but she wrote this book, The Child Who Never Grew, about her daughter. And what she wrote about it, I think, is so relevant to this group today. In 1950, she wrote of endurance of inescapable sorrow that she suffered, something which has to be learned alone. And she wrote that endurance is only the beginning. There has to be acceptance and the knowledge that sorrow, fully accepted, brings its own gifts. And sorrow, which can be transmuted into wisdom, which, if it does not bring joy, can yet bring happiness. And so what she said is, my own resolve shaped into the determination to make meaning out of the meaningless. Her life must count. I could not rejoice in the knowledge that others had the same burden that I had, but it made me realize that others had learned how to live with it, and so could I. This is one of our publications, but in the publication, you see a picture of Bond having his high density EEG. And from this work, we were able to report abnormal synchronization of the brain rhythms, especially the gamma activity, which was a sort of like unexplored frequency. When we talk about EEG, we talk about delta, theta, beta, alpha, but we don't really talk too much about the high frequency oscillations, especially gamma, which ties into GABA, which ties into intellect. And now we're doing MEG studies and synchronization studies. And it really came from the work that Bond did. So his participation really has pushed the field forward. And I had to show you this article where his work is actually in the article. We even have a picture of him here. And so with that, our summary is that inherited metabolic disorders pose an increased risk for mortality from lots of reasons: respiratory, cardiac, infections, GI. One of the risks for SUDEP is frequent seizures that don't respond to anti-seizure medications, and that's endemic in these inborn errors of metabolism. Many inherited metabolic disorders have a high occurrence rate of drug-resistant seizures, higher risk of SUDEP. And also, there are a lot of characteristics of these specific inherited metabolic disorders increasing the risk of SUDEP, such as cerebral edema. And so, we think it's important to try to control the seizures, but we don't really know that we have a way of preventing it. And that is the end of our presentation. Thank you so much.
I thought yours was so interesting, especially with older.
So this was a pretty spectacular first effort at talking about neurodegenerative disorders and epilepsy and premature mortality. So thanks to the speakers. We have time for some questions. I'd like to take the prerogative and ask Charity a question for starters. In your ultra rare community, are seizures discussed?
Yes. Yeah. With ours, absolutely. I was speaking with a woman earlier, and I felt, before we saw Dr. Pearl, I felt like I was a stalker because I had read everything that he had ever written on. And you become an expert as a layman reading these medical studies. And but the one thing, and I think maybe it was just for mental preservation out of fear, perhaps fear why some practitioners don't, or uncomfortableness, don't want to talk about SUDEP. I also did that with seizure activity because I had read that it was there, but I didn't believe it until it actually happened. And then I had to educate myself on a whole new system of what we were going to do. But yes, it was very much.
Laura.
Thank you. Is it on? Thank you to you all, and especially Charity. Thank you. I feel like I know Bond. You did such a beautiful job telling us about him. So I might get teary, but beautiful.
If you do, I will.
Ifra, I have a question. So that was beautiful. Sharing the information, which we do not, I agree with you, Dr. Pearl, do not talk enough about. This is the population with the highest incidence of new diagnoses, and we don't talk about it as a community. We need to. Where are the burning questions? You did a beautiful job laying out what we know. What are the next set of questions? As a funder,
Okay.
I want to know those things.
Yeah, okay. So I'm working on a bunch of different things. I just had to delete all of those slides because I just couldn't fit them in the 20-minute. So I'm now looking at neuroimaging biomarkers, like I said, for epilepsy and Alzheimer's disease and non-Alzheimer's disease dementias. We just submitted one paper in a wide variety of different ways. So we're looking at the hippocampus, we're looking at amygdala, we're looking at white matter burden, all of which things we think are significant in older adults, which you wouldn't think about in younger people. We are building a prediction model based on clinical and genetic risk factors to identify epilepsy patients early. I'm also recruiting 80 patients to undergo blood biomarker testing of tau, amyloid, genetic testing, EPOE, 24-hour EEGs, and I found myself a collaborator like 10 minutes ago who's sitting right behind you. I'm just looking like an epileptologist at the EEG right now, but our goal is to look at identify patients with and without epileptiform activity, and then perhaps we can look at their functional connectivity, and if there are some EEG features that we can identify also for their risk of developing epilepsy. And yeah, there are like 5 other things which I can talk to you about, but I think I'd stop there.
Okay, also for early identification, diagnosis, treatment, finding those markers.
Yes, exactly. Just to identify this patient population early, because I think the biggest issue here is identifying, because most older adults with epilepsy and persons with dementia respond well to medications.
Right.
And of course, there's room for clinical trials in like 5-10 years of down the lane in my career, maybe, to identify the right medications for this patient there have been some studies with Keppra, but not like a lot. But I think these are the questions which I think I'd like to focus on right now. Yeah.
Thank you.
Thank you.
Hi. There's a question to Philip. I enjoyed your talk, as always. I have a question for you. In these inherited disorders of metabolic function have high mortality, not all of which is related to seizures. Now, one of the definitions of SUDEP, or one of the requirements, is unexplained, as in no other cause. Given the high rate of cardiac and respiratory causes of death, how do you ever define someone as a SUDEP, meaning how are you able to exclude the other causes? They're found dead in bed, basically. So how do you exclude what happened that night?
Well, that data is so aggregate, there's so many metabolic diseases in that data. And some of these conditions, they're just not going to qualify as SUDEP, most likely. A maple syrup patient or a urea cycle patient, they're going to have massive cerebral edema as the most likely cause of death. But it's like any other case. You go with the autopsy data and the other clinical data, and if there's really no other explanation, we would regard it as SUDEP. So SSADHD is one of these neurometabolic conditions that actually has no visceral, no systemic pathology. Even though the enzyme is mitochondrial and there's plenty of it in the liver, there's no hepatic dysfunction in these patients as a rule, or any other organ system dysfunction other than the brain. So in the case of a Bond or the other SUDEP patients we've had with SSADHD, the autopsy data and the rest of the laboratory data and clinical data totally supports SUDEP. But you're completely right that a lot of these conditions, it would be most unusual to identify a SUDEP when there's an underlying cardiomyopathy or something of that nature. Yes. I would say, well, I think, with any SUDEP case, there's possible, probable, likely, something like that. And so it really depends on the condition.
This is so interesting because in people that do this for a living and talk about autopsy negative circumstances, sometimes they'll talk about doing the next step, which is the metabolic autopsy and drawing blood for the disorder that going into it. So sort of new ground.
Question over there, Jeff.
Dan?
Hi, my name is Marissa Kellogg from Portland, Oregon, and I have a question for Dr. Zawar. Incredible talks. Thank you so much. I was curious what other you mentioned genetic factors, and I know you mentioned ApoE, but what other ones did you look at?
So the ones that we had available were ApoE4, and the other dominant AD and some FTD mutations like Presenil 1 and 2. But I think the reason why we didn't find, although there are some studies that suggest that even the other dominant Alzheimer's disease mutation, like APP, PSEN 1 and 2, are also associated with higher risk of seizures. But we didn't find them to be statistically significant because I think they're just not prevalent enough. And, like if you have like 5 patients who have them in the sample, you just don't have enough statistical power to detect that difference. Whereas ApoE4 is so much more common that we were able to find the statistical difference. So these were the mutations that we looked at. But in future, and this also answers Laura's question as well, we want to do like, maybe if we can acquire some of the autopsied brain tissue, we can do a little bit more genomic analysis in detail, is also something that I have thought of going beyond these mutations. Yeah. Thank you.
Dr. Bateman.
My question is also for Dr. Zawar and follows up a little bit from Dr. Lover's question as well. When dealing with dementia populations, we have people who obviously have seizures, but we also have people who just fluctuate with their cognition. So how can we as providers and maybe family members or people who are caring for or living with people with disorders of cognition recognize or get appropriate counseling and intervention for people who have fluctuations, and to figure out, is this really seizures and how do we treat them appropriately versus they're just fluctuating a little bit and we'll make them actually worse if we try to throw too many medications at them?
That's an excellent question. I think I'm going to try to give you my perspective on it, and some other providers may have a different perspective. If I see patients who are fluctuating, because I feel like it's so hard to recognize. Like I had a patient with dementia who had this in my clinic, right? She just sat there for 10 seconds, she stared forward, and that was her seizure. And I told her daughter, she's having a seizure right now because I just saw it. And she was like, oh, she does this all the time. And then we sent her down to the EEG lab and we confirmed the seizure on the EEG. Now, this can be very hard for patients to find out. So if I sense fluctuation, and if somebody has even a question of an EEG, then I am going to push them towards an EEG, which includes sleep, because 80% of both seizures and epileptiform discharges in this patient population are going to be recorded in sleep. So, and then most of the discharges and possible seizures are recorded in 24 hours EEG, which can be very, very challenging to do in dementia patients. So another goal of our ongoing study is to identify optimal duration. My hope is maybe 4 to 6 hours in the lab where they can fall asleep, may be sufficient as long as we have a few hours of EEG. And what I'm seeing in most of these is that the patients who do have discharges, or at least frequent enough discharges, you will see them as soon as they fall asleep during in the lab. And then if you have like a lot of discharges, then you have some evidence of fluctuating cognition, then you can make an argument perhaps for a low dose treatment. But it all kind of is like that gray area where you can't pinpoint one way or the other. But there was a Keith Wassell's study in 2021 that showed that even with frequent discharges, if you treat like 125 milligrams twice a day of Keppra or levetiracetam, which is like not a therapeutic dose for seizure treatment, they could potentially have some cognitive benefit from that. But it's like a really small sample size, much bigger studies are needed. To summarize, I'm just going to say, I encourage them to get like a 4 to 6 hours EEG, trying to get sleep in that, and then I go from there with discussion, perhaps adding a really small dose, especially if they have some questions of fluctuation, because it's just so hard to understand what that is. But then I kind of guide the family, if you see, like, interact with them during periods of fluctuation. If they're not interacting, if they're clearly not there, then I would favor treating, even if at a very, very low dose, because most dementia patients will respond to 250 twice a day of Keppra, which you would never do for anyone younger than that, right? You'd be like, this is not going to work. So, thank you.
Dr. Naray.
Thank you to everybody for the great talks. I have actually a lot of questions, but I'm going to comment on this, what you just said about dementia patients, and I wanted to put out a call here for collaboration with dementia societies. And one of the reasons is because actually in the new dementia guidelines, it actually mentions that for clinical decision-making, you should not record EEGs unless there are seizures visible, which obviously we're all epileptologists. So for us, this is exactly to some extent an absurdity, but I understand this sometimes because in a non-epilepsy center, there's a lot of false positive EEG reports that are being sent to caregivers and primary physicians that have no idea about EEG reading. So I think this is more a call to action and be like, let's work together with the Alzheimer's societies to kind of and be better in reporting EEG accurately for them to kind of help that. So that was just a side comment I find quite interesting to just, make awareness that the guidelines of other associations go against.
But I think those guidelines are if they don't have any fluctuating cognition or possible suspicion of seizure.
Exactly,
right?
Possible suspicion of seizure. And your point was just
so I think
sometimes
her
that's
question was if they have fluctuating cognition and you suspect it.
Yeah, but you suspect, that was your point, right? You suspect it because you're trained as an epileptologist and you see this in a clinical consultation with the family. If you were not an epileptologist, you would say, well, this is a normal cognitive, like up and down, of like whatever.
Yep.
So it was more of a comment to just, that we should all kind of also keep in mind that the majority of these patients are not seen by epilepsy physicians, and we can just be better in supporting those caregivers as well in that sense. I had a question though, which is more to the one of the slides that you made, and it kind of links of my firm belief that some of the DE pathologies share neurobiology with actually dementia as well. And you showed this on one of the slides really well, where you say, brain atrophy, temporal lobe atrophy, and those things are shared amongst or higher in those with high seizures. And you also mentioned amyloid, and I was wondering, do you know, and maybe I should know this, but do you know, are there any studies that look at the amyloid plaque of patients that don't have any cognitive impairment in terms of dementia, but do have seizures? So is that something, maybe a marker that isn't even dementia specific, but could be seen in non-dementia patients with seizures as well?
Yes, so there are a lot of studies, and we are doing a systematic review right now to put all of those together, because that's the next step that I want to do. I want to look at patients who don't have dementia, but they have epilepsy, and then find out their neuropathology. There is some evidence from studies because a lot of patients who undergo temporal lobe epilepsy, who may not have any real cognitive impairment or some subjective cognitive impairment, but not in MCI or dementia, have been studied by various groups. They have looked at both amyloid and tau. I think there are at least like 15 studies, small sampled, but they have shown that there's evidence of both amyloid and tau in resective tissue of temporal lobe epilepsies and even other epilepsies, especially in the hippocampus, which is seen in patients without any evidence of dementia, or not even like late onset epilepsy. This is like just general epilepsy, drug resistance epilepsy, who underwent surgery and then they studied it. But so I think it has been proposed, and even within temporal lobe epilepsy, who underwent surgery and had a high tau burden, these patients 10 years down the lane developed dementia. They didn't have dementia at the time that they analyzed the brain sample, and they didn't have any cognitive. So there is evidence that there is tau and amyloid in the brain of patients who don't have any cognitive impairment, who just have epilepsy. And there are several mouse models that also show that seizures can increase tau secretion and spread, and same for amyloid. I think the link is more with tau, but it has been shown for amyloid as well. Yeah.
You.
Hey, this is a short comment to Dr. Pierce's conclusion. Yes, metabolic disorder is not rare. According to our recent finding, we found that metabolic disorder is one of the main causes of death related to epilepsy. Thank you.
Also, that's related to epilepsy, and from the CDC. So, yes. Thank while I have you for a second, talk about GABA and excitation and inhibition, EI balance. What have you learned from network studies, which make it a little bit more specific than all GABA in the brain, all glutamate in the brain? People usually approve. People usually like that. The question was, we talk about inhibition, excitation, as if it's a global CNS phenomenon. The question was, have we learned things from, say, network studies that can make the excitation and inhibition a bit more specific?
Well, there are so many aspects to that. One, there are ontogenic aspects of that. In other words, as the organism ages, GABA changes in its role. So in the fetal brain and the early neonatal brain, GABA is actually depolarizing. It's actually hyperexcitable due to the chloride transporters. And the way, when GABA binds to its receptor, they're GABA A and GABA B receptors, but we'll stick with the GABA A receptor. Chloride goes into the cell, but in the immature neuron, chloride extrudes and the cell becomes more positive and depolarized and excitable. So that all changes at a few months of life. So the first thing are these ontogenic changes in GABA. The second thing is, one of the most important things in developmental neuroscience is how does the brain compensate? Not just the injury that occurs, but how does the developmental brain compensate? And we found using flumazenil PET studies, because the flumazenil binds to the benzodiazepine receptor of the GABA A receptor, that they downregulate their GABA A receptors. And there are other studies in the animal models showing they downregulate GABA B receptors. So there are compensatory changes in time. That's the second thing. So ontogenic things, compensatory things. Third thing is, as you're suggesting, Jeff, GABA is not uniform. They're tonic and they're phasic components to GABA inhibition. And the regionalization of GABA receptors is not uniform throughout the brain. They're really high in the basal ganglia, particularly in the globus pallidus, where the MRI abnormalities are in SSADHD. Glutamate's really high in the hippocampus, which makes sense. You have to learn everything with all that excitation. So the distribution of GABA receptors is another difference. Networking studies. Wow. We are currently involved in something called MEGAPRESS, which is a sequence where we can actually measure GABA using MR spectroscopy. We're involved in something called CEST imaging, chemical exchange saturation transformation or something. We're measuring chemicals in the brain using MR imaging. We're involved in G-ratio imaging, quantifying myelin. I'm going to be talking about these things in a talk on imaging in metabolic epilepsy Saturday morning and during the presidential symposium. And we're getting involved in connectivity studies in the SSADHD population, but the data is so preliminary, I don't have any results. So I don't really have a very specific answer, but I think, Eitan, you said you might have some comments.
Just add something small. So I'll just say 2 years ago, during the AES, I met Shlomo Shinar outside of one of the lectures. And I don't know if you remember this, Shlomo. I asked you, if you would have all the money and time in the world, what one research would you do? I don't know if you remember this. And you said to me, you thought about it quite a bit, and you said to me, why don't you research the people that in whom epilepsy stops on its own, so without our intervention, right? The absence epilepsy that just resolves, the Rolandic epilepsy that just resolves. Study their brains, because the answer is there. And I know it's in fashion now to talk about GABAergic networks, in relation to epilepsy stopping on its own. One of my hypotheses is that in SSADHD, there is some kind of disturbance to these GABAergic networks, obviously because of the GABA disturbances. And that is related to what you said, Dr. Pearl, about studying these GABAergics using the MEGAPRESS and other mechanisms. This is, I think, one of our future plans in the next 5 years, hopefully leading to insights in that direction.
So other than the 6 questions I have, in the interest of time and getting everybody to the next plenary, I'd like to thank our speakers who were phenomenal. Thank you all for being here, and ask you to please, on the evaluations, let us know if this is a useful breakout. If so, what would you like to hear next year? What would drive you to come? And that's really what this is all about. Hearing a speaker say right off, I found a collaborator and I got interesting questions from a funder, made it all worthwhile. So thanks, everybody.
I would like to add one last thing. So the collaborator I found, I told her about you, and I said Jeff, but I can't say his last name, so I don't know how to thank him. And she said, just thank him and say Jeff with a bow tie.
Very welcome.
So thank you so much.